This meeting is being recorded.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. For the record, please note that Dr. Michelle Allen is representing Dr. Katz, both in presence and in voting capacity. So, let me start. On the agenda, next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on January 9, 2023.
So move.
We have a motion?
Yeah.
Do I have a second?
Second.
So, am I pulling everyone individually or?
Whichever way.
Yes, okay. Dr. Pagan?
Yes.
Dr. Allen?
Yes.
Jackie Rowe Adams?
Yes.
And myself, Dr. Marthone, yes. Thank you, everyone. Next is a diversity and inclusion update from Ivelisse Mendez Justinacio.
Liana.
Daniel. My apologies.
No worries. Good afternoon, everyone, and thank you for allowing me the opportunity to present our updates. Today, we will be presenting our system-level activities for the Office of Diversity, Equity, and Inclusion, which will be followed by the Equity of Access, Equity of Care Council, which will then be followed by our Vendor Diversity Program update, and lastly, we will close off with our EEO report. So we thought we would start off with an overview of our ODEI organizational chart. And this is essentially provides information on our scope of services provided by our office. So we work with many stakeholders. Our primary stakeholders are human resources, EEO, and MWBE. We have oversight of language access, gender equity, education and capacity building, and all DEI topics. And we're starting a new focus on disability awareness as well as veteran services. Now, we don't do this work alone. We are informed by several councils, amongst which are included the Language Access Council, the Pride Health Advisory Council, the Equity and Access Council, which we'll be presenting today. And then, as I stated, we have a new focus, and we will be convening a new council to advise us on disability as well as veterans. So I spoke previously about educational and capacity building. And so system-wide, we had, and this is a moment in time in 2023, we had an average number of employees of 43,550. And so when we looked at all of the training that we provided during that year, we had 48,771 completions, which means some employees took more than one training. Our top 5 trainings were identifying and managing unconscious bias, culturally responsive services at New York City Health and Hospitals, LGBTQ awareness, achieving health equity for LGBTQ people, which was held virtual and in person, disability and inclusion in a healthcare setting, and Let's Talk Disability, which was our inaugural training. If you'll notice, the Identifying and Managing Unconscious Bias has 41,871 completions. That is a mandatory training for all employees at New York City Health and Hospitals. Next slide, please. And this is an overview of all of the other trainings that are provided by our office. Some of these are trainings that are requested by particular departments. Others are focused on particular groups. And they cover different topics such as racial differences and disparities in healthcare for African Americans. We did combating imposter syndrome as part of Hispanic Heritage Month. We had the impact of race, of workplace dynamics, religion as a social determinant of health, and many others that we provide. In terms of language access, we completed over 2023 English source documents translated into other languages across the system. With these translations, we had over 30 languages represented, and the data for these services provided was from January 1st, 2023 to December 10th, 2023. That's regarding written translations. When we speak about spoken language interpretations, we had over 2 million interactions with interpreters provided across the system. Of those 2 million interactions, we had over 29 million minutes of interpretation that was provided across the system. When you break down the interpretation provided, our top 5 languages were Spanish, French, Haitian Creole, Bangla, and followed by Russian. And the data provided for these services is January 1st through November 30th, 2023. Continuing with the provision of language access services, we also were able to launch a medical interpreter skills training program, which we affectionately call MIST. 72 staff members across 15 sites completed the program to become qualified as volunteer medical interpreters. And we had 4 languages represented. We also had a special Haitian Creole cohort at Kings County, which began at September. Now, the way these trainings occur is that in order for you to be accepted into the program, we first have to ascertain that you speak the second language at a level proficient enough to complete the training. So therefore, 350 staff applications were received. Once they went through the competency assessment, 159 were accepted. This represented 21 sites across the system, and we spanned 10 languages: Arabic, Bangla, Chinese Cantonese, Chinese Mandarin, French, Haitian Creole, Hindi, Korean, Russian, and Spanish. We also had another cohort, which is in progress now, which started in 2023 in December. So that will run from 2023 through 2024. In addition, I spoke previously about the Language Access Council, and so we convened 4 times during 2023 across the system. I also mentioned our new focus on veteran services, and so to provide you with a little bit of background on this, we currently have a population, a self-identified population of 402 employees who are veterans. And again, it may be more, but these are the ones that self-reported. The goals of this particular focus is the creation of a Veteran Advisory Council to inform us of what are the needs of the veteran community, particularly our patients, our employees rather, because we want to make sure that we are providing and engaging them with the services that they need. Ultimately, we would like to become a military-friendly organization, which all of these things will contribute to. We will be providing educational opportunities to veterans, increase use of veterans' benefits for employees and their families, include veteran-focused recruitment in our talent acquisition strategy. So this is something new that will be introduced. Also, we're in the process of launching veteran pop-up sites throughout the system, beginning with Metropolitan Hospital. And what this means is that we will have a representative that is aware of all the military benefits, and they will be available to meet with staff, our staff that are veterans, and inform them of this. So we've started with Metropolitan, and we have 3 other facilities that have already volunteered and are looking forward to getting it on site. Our outreach initiatives, we started off with a symposium during Veterans Month. We also are also looking at recruitment fairs and partnering with the New York City Commissioners of Veterans Affairs. In our Veterans Symposium, we actually had the head of Veterans Affairs for the city. Our commissioner came and joined us. He delivered the keynote speech. This was our inaugural Veterans event. It was entitled Serving Those Who Need. We did it in partnership with Central Office Communications, and we also released system-wide communications supporting the event. It was held on November 16th at Gouverneur, and we had 137 participants. This event was in person, and it was also live streamed. Also, with disability awareness, our new focus area, we launched a Let's Talk Disability training, which was comprised of 4 sessions between June and September. We had a total of 232 participants. These sessions really provided a better understanding of what constitutes a disability, whether it's visual or not. We taught the appropriate terminology and behaviors for being inclusive of colleagues and patients that may show disabilities. After completion, staff received a certification of participation, also accompanied by a Disability Ally pin that they can wear to let staff know. In terms of culture and heritage outreach, we had several events celebrating all of our employees, and these included Juneteenth, Hispanic Heritage Month, Lincoln Hospital. At Lincoln Hospital, we had Polish American Heritage Month, Italian American Heritage Month, Filipino Heritage Month. We also participated with the inclusion groups in the West Indian Day Parade. And these are pictures. It was very well received by staff. In terms of leadership development and looking at our future workforce and developing our existing workforce as well. We participated in America's Essential Hospitals Fellows Program, the Bloomberg Fellows Program, and the Haney's Healthcare Middle Manager Training. In terms of internships, we worked with the Career Ladder Program, among many others. We're partnering with local high schools. College partnerships include CUNY, NYU, John Jay College, St. John's, and we're continuing to bring them. In terms of participation with our interns, what we notice is that future work to be done is to balance the number of participants that are working that are participating in the internships so that we can increase the number of African American and Hispanics participating in our internship programs. In terms of loan repayment, the Office of Mental Health Community had a specific diversity, equity, and inclusion set-aside fund. Of the 47 of the 70 submitted applications were eligible for both their student loan forgiveness as well as the set-aside fund. And you can see the participation here. 29% was African American, 27% Hispanic, 33% Caucasian, and 11% Asian. The Food and Nutrition Fund, again, providing opportunities for our staff for professional development. We had individuals participating in the Certified Dietary Manager Program, the ServSafe Food Handler Certification, the ServSafe Manager Certification, the Department of Health Food Handler Certification. We also provided reimbursement and CUNY vouchers for professional development and advancement for staff, as well as client-directed service certificate programs with Cornell University. And lastly, we have our gender equity update. We participated in the Healthcare Equality Index biannual service, and the results will be forthcoming in the next quarter in 2024. We also launched the Mental Health Training Project in collaboration with IHI, and that's to increase affirmative care to all our LGBTQ employees and patients. In terms of awards, we received the Leader in Long-Term Care Equality. New York City Health and Hospitals was recognized as a 2023 LGBTQ+ Long-Term Care Equality Leader by the Human Rights Campaign and SAGE. We also participated and received the International Inclusion Award in 2023. We were named a Diversity Champion for Non-for-Profit Award, and this was by the International Diversity Mark. In June 2023, we were also presented by Elmhurst Leadership as a Strength and Solidarity Award for the work that we've done in diversity. In terms of training, we provided the Certificate of LGBTQ+ Health Equity, which boosts providers' knowledge and skills delivering equitable, compassionate, and affirming care. The largest participation came from Elmhurst, with a total of 217 individuals completed the training. And this concludes my report, and I will now pass it off to Equity and Access Council. Dr. Cenaz.
I'm sorry, I just want to stop here for a moment and ask our board members if they have any questions. I will poll. Dr. Pagan?
Yeah, that's a great presentation. I have a few comments or questions along the way. One is you talked about the medical interpreter skills training program. As I was looking at the presentation, we had a lot of participation. But then I wasn't sure whether for the Haitian Creole you had 18 staff members that did it. Did you have more interest on it, but only 18 could do it?
So that was a specific cohort that took place at Kings County Hospital.
Okay.
So at Kings County, we had 18 employees participate, but when we run our regular MIST interpreter skills training, we have more staff that's participating system-wide.
I just wanted to make sure that
Yes.
the staff that wanted to do it had an opportunity to do it.
Oh, absolutely. And it's ongoing, so we will continue offering that
Then
program.
once they do that, not that there's a need for financial compensation of any type, but are there any, I'm trying to understand the incentives when they do it. Do they either get the time off to do it, or do they get?
They volunteer. But I can tell you, as we sit through I think it's a personal moment of giving back as well when people speak a second language. I can tell you when new employees walk in the door and we ask them if they speak a second language and we talk about the provision of language services for patients, one of the first things that the employees ask us is, can I help? I speak a second language. And actually, what comes through is the pride in speaking a second language. So we find that every time we launch this medical interpreter skills program, we have a slew of individuals, a large cadre of individuals that are interested in the program, even though it is a volunteer program.
And
I was going to ask your question a different way. Do they, surely they volunteer, but do they volunteer, can they do this during their 8-hour workday? Or do they have to do it after hours?
Oh, no, they do it within their 8-hour day. With clearance from the supervisor, make sure staffing levels are adequate, they are able to take time and interpret. The beauty of it is as well, if someone comes into your area and you have been trained to provide interpreter services, then you can also assist without having to leave your area of work.
Thanks.
And I was gonna say, love the veterans work that you seem to have launched. I mean, very, very important initiative. And one comment also on the leadership programs, workforce development programs, like one, I don't know if the level of support that we provide in terms of nominating our employees for activities like this is high or low. It's hard for me to assess. We're a large system. But I know one thing that at universities, for example, that I've seen that where I'm at, we're doing, for example, is like, there's like a committee that somebody thought it was a good idea to nominate people for things. And they have like a committee where they make an extra effort to nominate folks. And I'm always impressed by the level of talent that we have in our system. But I always wonder if like, how can we get them to apply to fellowships or, you know, any of these sort of programs that exist out there?
So we send out a system-wide leadership blast as well as all employee blasts. And so we find that employees self-nominate. But personally, I've seen this particular year, I've had requests from CEOs, I've had requests from different leaders nominating. I have seen an increase specifically for America's Essential Hospitals. So much so that we already have a waiting list for next year's cohort.
That's great. Yeah.
Thank you, Jackie. You're up.
So, yes, early on, when you talk about the training, so it's different trainings, but how do you recruit?
Oh, several ways. So we have our diversity and inclusion website where all the trainings are posted. We send it out via our monthly Learning Academy calendar where we put all the trainings as well. In addition, we instituted a new monthly diversity newsletter where the trainings are published as well. And then we also reach out when I go to the sites. I visit with leadership, I participate in town halls, my team goes out, and we try to socialize it as much as possible, and that's how they know the trainings that are taking place.
So the age group range, is it just adults, is it teenagers, how do you?
The particular trainings that we're offering right now are for our workforce, so the age varies in terms of the individuals that participate. However, we are working with different high schools and developing internships and things like that. And so those would be high school students, college students that participate in the training.
Thank you.
Thank you.
I
Dr.
have no
Allen, any
questions.
Thank you.
I just want to remark on that's a tremendous body of work, so thank you very much.
Thank you.
Ditto from myself as well. Thank you. Next is an update from the Equity and Access Council, Natalia Sinise and Nicola Davis.
Good afternoon, I'm Natalia Zinnias, Chief Nurse Executive. Dr. Davis is unable to attend today. Next slide, please. Just to provide an overview, the Equity and Access Council governance structure comprises of 4 work groups: workforce diversity, workplace inclusion, equity of care, monitoring, and evaluation. Today's presentation will focus on equity of care, which is charged to develop strategies to eliminate racial and social, institutional, and structural inequities. Today's presentation, I want to thank Dr. Einstein. He is a primary care doctor at Kings County, but also Director of Health Equity, Social Determinants of Health team here within the Office of Population Health. Thank you so much.
Thanks, Natalia. Great to be here, everyone. Thanks for having me. One thing to start with is just to be really clear about the structure of the Equity of Care work group. We don't lead these projects, but instead we elicit proposals from facility level staff and clinicians, and then we'll basically guide and facilitate and develop these proposals usually leveraging central office and cross-facility collaboration to do so. So I'll be giving an update today on 4 of these projects. In the interest of time, I'll focus on, sorry, if you could go back one slide. I'll be focusing on ending racism in clinical algorithms, equity and access for persons with disabilities, and sickle cell disease management, partly because the Increased Access to Pregnancy and Abortion Care project has launched successfully, and we're really excited about it. Next slide. So for ending racism in clinical algorithms, you can go to the next slide. This is a project led by Dr. John Wagner, nephrologist at Kings County, as well as myself and Nicola Davis. And the goal of this project is to eliminate race-based algorithms in the electronic medical record that may adversely impact health outcomes and create inequities in treatment plans. Just a little bit of background here for anyone non-clinical who may not be familiar with these. So for many years, healthcare has relied on clinical algorithms that individualize risk assessment and guide clinical decisions. And many of these clinical algorithms had explicit race variables. So race was actually baked into the algorithm itself. And the algorithm's output would be different for patients of different races. The most commonly cited example of this is EGFR, which estimates a patient's kidney function. So the algorithm systematically uses race and used to adjust to a healthier value for Black patients. So if you imagine 2 patients, for simplicity, 1 Black, 1 white, and all the other inputs to the algorithm are exactly the same. But then for that Black patient, the algorithm would adjust to a healthier value. The concern here is that if we're systematically adjusting to a healthier value for Black patients, that we might be guiding decisions in ways that direct actually more attention or resources to white patients than to members of ethnic and racial minorities. So in 2020, I had the opportunity to co-author an article in the New England Journal of Medicine that looks at these concerns and specifically goes into, explores 13 of these algorithms and the ways that these race adjustments might be contributing to worsened health disparities. Now, in the past few years, there has been a lot of momentum to reevaluate these algorithms and, when appropriate, to actually revise them to address this race adjustment. And one example of this momentum is the Department of Health and Mental Hygiene's Coalition to End Racism in Clinical Algorithms. Health in Hospitals has been a core participant in this coalition. And I'm going to review some of the changes we've made as a system as part of this coalition. So one change we made is we've actually implemented changes in 2 of these algorithms. One is EGFR, one is vaginal birth after C-section. And ongoing, we are pursuing opportunities for awareness raising with the National Kidney Foundation about chronic kidney disease. And additionally, we have completed an analysis to understand the impact of the change in the kidney function algorithm here within our system. And I'll be sharing with you some of the findings from that analysis. So the first question we asked is, okay, we've changed this algorithm. Now, what does this mean in terms of the estimated kidney function for patients in our system? So to orient you to this graph, this is EGFR, which is kidney function estimate, values for 9,000 Black patients who were seen in the 2 time periods before we changed the algorithm and then after we changed the algorithm. On the y-axis, you have the number of Black patients seen within these 2 periods. And on the x-axis, you have sort of buckets, different ranges of EGFR. So if you look all the way to the right-hand side, EGFR greater than 60 is basically accepted as the cutoff for normal kidney function. So EGFR greater than 60, no major concerns, your kidney function is good. As your primary care doctor, if I see that, I'm basically saying, looks good, see you next year. It's when we get below EGFR of 60 that we start to say, okay, what's the cause of this kidney disease? What do we have to do to prevent it or to prevent worsening of it? So we start to think about interventions and further evaluation by specialty care. So this graph shows that in terms of the impact of the algorithm change, for Black patients seen in both time periods, before the algorithm change and afterwards, fewer of these patients were the in the group of EGFR greater than 60, and more of the Black patients were seen in the subgroups of EGFR less than 60, or in these categories of chronic kidney disease. So in other words, more patients, after we made this algorithm change, more Black patients were identified as having chronic kidney disease. Next slide, please. So the next question we want to know is, okay, we've identified more patients in our system who identify as Black and have chronic kidney disease. What does that mean in terms of their access to care? So this graph shows referrals to nephrology for Black patients and whether or not they were completed within 90 days of the referral being placed. So again, to orient you, on the y-axis is number of referrals, and on the x-axis again is these ranges of EGFR. And the orange part of these columns is referrals were completed within 90 days, and blue is those referrals were not completed. So if you direct your attention all the way to the right-hand side, basically what we're seeing is that a lot of nephrology referrals are not completed within 90 days. And in fact, only about a third are completed within 90 days. Now, from the pre-algorithm time to the post-algorithm time, we're not seeing a dramatic difference in the number of referrals completed within 90 days. And this is not very surprising finding, right? Because the intervention here was at the level of the algorithm itself. There were not any changes made in this intervention to the system's access to nephrology care. So to summarize the findings of the analysis done related to the fact that we changed the EGFR algorithm to no longer include a race adjustment, EGFR, the change was associated with more Black patients who had an EGFR less than 60, meaning an EGFR that gets them into the chronic kidney disease range. And this raises concern for previously underdiagnosed chronic kidney disease. And I want to be crystal clear here that this is not an H&H specific issue. Nationwide, there is a reassessment and reevaluation of the EGFR algorithm. And across the country, we are acknowledging that there is likely previously underdiagnosed chronic kidney disease in patients who identify as Black. Additionally, we saw an increase in nephrology referrals for most patients, including Black patients. And an important finding that I want to highlight is that this increased nephrology referrals was not associated with more timely nephrology evaluation. So only about a third of the system-wide nephrology referrals resulted in actual nephrology evaluation within 90 days. One important caveat here is that this finding includes no-shows. So it includes the scenario where someone actually was referred to nephrology and within 3 months actually was scheduled for a nephrology appointment, but for all the reasons that we know, including social determinants of health and inadequate sort of things like childcare or not being able to get off work, patients didn't show up for those appointments. It includes no-shows, but it also includes scenarios in which a person was referred for nephrology care, but that appointment wasn't available within 90 days. We spoke with the nephrology system lead, Dr. John Wagner, who runs this project, to understand, what are some of the initiatives taken by nephrology to improve access. So these include things like a monthly review of ambulatory practice data, including metrics like the next available appointment, no-shows, and the median time to scheduling. At least one facility has opened an additional ambulatory slot for nephrology. There's increased adoption system-wide of e-consult for nephrology. And the Epic scheduling team has created a pathway such that if an opening appears in the practice schedule that permits an earlier a patient to be scheduled earlier than the originally scheduled appointment, then they're able to offer that earlier appointment. So the reason I just want to highlight this is that there's been a lot of interest and attention on these race-adjusted algorithms, and while it is a really important sort of example of equity work within healthcare, these changes that we're making to the algorithms themselves may at times be overshadowed by broader issues of suboptimal access to specialty care. So in terms of next steps, as I mentioned, H&H is a core participant in the DOHMH's Coalition to End Racism in Clinical Algorithms. And the coalition is heading towards their sort of 2.0 phase, where they are starting to focus on access to transplant as a key site of the impact of EGFR. And the reason is, as I mentioned earlier, EGFR, a key sort of clinical sort of decision point is about EGFR greater or less than 60. But there's another EGFR point that's really crucial for a person's clinical trajectory, and that's EGFR greater or less than 20. A criterion for getting onto the wait list for a kidney transplant has historically been EGFR less than 20. Your EGFR has to be less than 20 before you can be placed on the waiting list, before you can start to accrue waiting time, which, as we know, is so crucial. And as more interest and concern was raised about EGFR and the race adjustment, people were realizing that this might have been systematically delaying Black patients' access to the transplant waiting list. And in fact, in June of 2020, the directors of the United Network of Organ Sharing, which administers the nationwide transplant system, acknowledged that a modifier for patients identified as Black has led to this systemic underestimation of kidney disease severity for many Black patients. Specifically in organ transplantation, it may have negatively affected the timing of transplant listing or the date at which candidates qualify to begin waiting time for a transplant. So this is a significant acknowledgement by the United Network of Organ Sharing. And just 2 months ago, January 2024, all transplant programs were required to look at their waiting lists and say, would a race-neutral EGFR calculation show that Black patients should have qualified sooner to start gaining waiting time for a transplant? And if so, these transplant centers are going to be required to submit waiting time modifications for Black candidates affected by the race-inclusive EGFR. So this is a huge deal in the transplant world, and I'm already hearing stories of patients, Black patients, getting letters in the mail that say that their history on the transplant waiting list has been evaluated, and their wait list time has been cut dramatically. I've heard situations where people's wait time has been cut by a year or 2 years because their transplant centers are acknowledging the impact of EGFR. So what does this mean for H&H? Since H&H is not a transplant center, we're limited in our ability to affect transplant access, but it raises this question that I think is a really valuable one. Is there more H&H could do to support patients who may benefit from a transplant? And so the next steps to sort of start to get at this question are supported by a grant. You can go to the next slide. Supported by a grant that the coalition, the DOHMH coalition, received from the Doris Duke Foundation. And as part of that grant, the New York Academy of Medicine has been enlisted to help us develop an evaluation plan for health and hospitals, for our patients, to understand what is the impact of EGFR change, both at the EGFR less than or greater than 60 point, but also at the EGFR greater than less than 20 point. And what is the status quo of transplant access for our patients? So this evaluation is going to include analysis of things like, what are the workflows within nephrology clinics related to patient education? So what kinds of education are patients getting across our system in nephrology in terms of their options as they are approaching kidney failure or end-stage kidney disease, or when they're already there? Additionally, the evaluation is going to look at what our clinical team's competence like in honoring patients' values and beliefs regarding their options for end-stage kidney disease, such as dialysis and transplant. So this evaluation plan is underway, and for the next couple of years, we're planning to carry out this evaluation. One last thing that I'll point out is, in the next slide, thanks, is that, you know, a clinical algorithm doesn't require a race variable in order to produce racist or racialized outcomes. And this is one of the emerging concerns in the sort of AI and clinical algorithm world. So it's important to assess all the algorithms we're using for possible bias and not just those that include a race variable. So for that purpose, we have gotten a grant that is looking at bias in electronic medical record algorithms from a group called Schmidt Futures. It's run by myself and Remley Newton-Dane, the Office of Population Health. And the goal here is to investigate bias in 5 algorithms that are in our electronic medical record and identify strategies to mitigate any potential bias. And those algorithms are risk of unplanned readmission, risk of inpatient falls, risk of asthma hospital admission or ED visit, outpatient no-show, and deterioration index. So again, I'll go more quickly through access to abortion care just in the sake of time. This is a project run by Dr. Musa Nadash. Goal is to increase access to pregnancy care, including abortion, across the health and hospital system. And we're excited to, share that the initiative has been launched as of summer 2023. And it's leveraging the Virtual Express Care platform to offer virtual on-demand abortion care. So next I'll go somewhat quickly through access to care for persons with disabilities. This is a project led by Dr. Michael Shen. And the background is that evidence suggests that persons with disabilities receive screening tests at a lower rate than the general population. Contributing factors include limited access to transportation and just lower rates of tests being ordered by clinicians. So in terms of H&H background, sorry, if you could go back quickly. Since 2012, H&H has partnered with an organization called Independence Care Systems to improve access to care for persons with mobility disabilities. So this has looked like, a specific partnership with 5 facilities: Morrisania, Lincoln Hospital, Cumberland, Woodhull, and Gouverneur. This has included things like sensitivity and awareness training to over 250 H&H staff, competence training on equipment like patient transfer lifts, that's crucial for outpatient and all care for patients with disabilities. And at Morrisania, there was a particular achievement of a renovated radiology suite that improves access to modalities like mammography for patients with disabilities. In terms of next steps, the main thing is that the Independence Care System organization has obtained a grant to further this partnership with health and hospitals. Our goal is to create a center of excellence for disability competent care at H&H. The focus specifically is people with a physical disability and wheelchair dependence. And progress to date is they have successfully embedded what they're calling disability liaisons in the Woodhull Primary Care Clinic. And basically what they're doing is observing clinic workflows and offering recommendations. They're preparing these recommendations now. One of the key ones that's coming up is that in our system, and this is a problem nationwide, there's no standardized practice for documentation of disabilities in EPIC. And so when we have sort of an inability to characterize the extent of an issue, it's hard to intervene upon that issue. So one potential collaboration upcoming with DNA is to consider strategies for improved system-wide documentation and data collection. So the last project I'll focus on is for access to care for patients with sickle cell disease. This is a project that's run by Dr. Ken Rivlin, who's a pediatric hematologist at Jacobi. And the background here is that sickle cell, as many of you probably know, is a key example of racial health inequity from bench to bedside. And I just want to share a couple of striking statistics in terms of the disparities in research. So if you compare the research investment for sickle cell relative to cystic fibrosis, which is another chronic congenital condition, sickle cell actually has a higher incidence in the US than cystic fibrosis. But when you look at the amount of investment that is going into the research for these two conditions, at the NIH level, research for cystic fibrosis is funded at a ratio of 3 to 1 compared to sickle cell disease. At the industry level, research for sickle cell, research for cystic fibrosis is funded at a ratio of 2 to 1 for sickle cell. And then if you look at philanthropy investment in research, that ratio is 80 to 1. So as a result, fewer trials have been funded, fewer articles have been published in the medical literature, and fewer treatment options have entered the marketplace for sickle cell. And of course, this disparity extends to the bedside. Throughout the history of the disease, patients with sickle cell have struggled to have their reports of pain believed. Here at H&H, we do a really good job taking care of children with sickle cell. We have 6 hemoglobinopathy centers for pediatrics where pediatric patients get comprehensive care for sickle cell. And but then when you look at the adult services for sickle cell, we have only 2 comprehensive adult sickle cell centers within our system. As a result, there's a significant drop-off in primary care doctor engagement for patients with sickle cell when you transition from pediatrics to adult. So among pediatric patients with sickle cell, 83% of them who touch our system have a health and hospitals primary care doctor. When you look at the same population for adults, that proportion drops down to only 50%. Difficulty accessing comprehensive sickle cell services contributes to a vicious cycle of fragmented care, distressing hospital encounters, higher rates of ED visits, hospitalizations, and readmissions. Just last year, the Office of Quality and Safety had a really powerful awareness-raising event for sickle cell. And a sickle cell patient herself and advocate for sickle cell disease, Candace Dealer, shared a very poignant story. She said, "Each time I go to the ER for a sickle cell pain crisis, I start crying. It's not because of the pain itself. Rather, I'm crying because of the uncertainty. What random ER doctor am I going to be assigned to this time? And will I have to convince them that my pain is real?" So the goal for this project run by Dr. Rivlin is to optimize the quality of care that we're providing for adult patients with sickle cell, to leverage system-wide data to inform and standardize best practices across health and hospitals, and crucially, to create pathways for pain management for pain crises that are outside of the emergency department. So the way that we're hoping to do this, you go to the next slide, is to leverage a successful model within our system, as well as guidance from our system-wide experts. So in 2013, Queens Hospital developed a model for a comprehensive sickle cell center. They hired a dedicated NP to streamline sickle cell care. And what they've found is that from 2013, when it started, to 2018, there has been a reduction in hospitalizations, reduction in 30-day readmissions, and reduction in the length of stay for adult patients with sickle cell. So this is a graph that comes from a presentation by one of the Queens Hospital staff. It stops in 2018 because they last ran this analysis before the pandemic. But to orient you, so this is looking at number of admissions and number of sickle cell associated patient days from 2013 to 2018 at Queens Hospital. The y-axis is not on the left-hand side is patient days in the hospital. The y-axis on the right-hand side is number of admissions. That corresponds to the blue line. And on the x-axis, you have the fiscal year. So what you see from 2013 to 2018 is a reduction in the number of admissions that patients at Queens Hospital are requiring for sickle cell care, the number of days they're spending in the hospital. And I'll just, remind that each of those reductions corresponds to a reduction in a patient with sickle cell having to experience what was described by the patient advocate of having to show up to the ED with a pain crisis, get admitted, and have a potentially very distressing experience. So in addition to leveraging the sort of internal expertise, we're also going to be leveraging guidelines from American Society of Rheumatology. And the goal is, again, to optimize care for sickle cell and ensure that H&H is doing right by this vulnerable population. I'll end with just a preview of some of the internal analysis that we've done to situate the Queen's example within the larger system. So we are considering a business plan to replicate the Queen's model across health and hospitals. And we have done an analysis basically to understand what is the volume of patients being seen at different facilities. And this is a graph that shows patients with sickle cell and associated inpatient admissions by facility in 2023. On the y-axis is the number of patients, and on the x-axis is the facilities. The blue column is number of patients with sickle cell attributed to that facility, and the orange column is total sickle cell related admissions. So a couple things I want to point out here. One is currently Kings County has the highest volume of patients by quite a margin. And it's not a particular surprise because Kings County is one of the two facilities with a comprehensive, long-standing and robust comprehensive adult sickle cell center. The other dynamic that I want to point out is the ratio of patients to admissions according to facility, because I think this sheds light on how adult patients with sickle cell engage with our facilities. So to take the Kings County example, there's 442 patients attributed to that facility in 2023 and 283 admissions, so a little more than half in terms of that ratio. Similarly with Queens Hospital, 167 patients, 87 admissions. But at the rest of the facilities, the number of admissions is almost on par with or sometimes exceeds the number of patients attributed to that facility. So in other words, the facilities with devoted sickle cell centers appear to do a better job keeping patients out of the hospital, which of course is a system priority, but more importantly reflects better experiences for patients. And just to impress upon you this point one last time, every time a patient comes to the ED or is hospitalized, it's another encounter of potential distress, another person who may struggle to have their pain believed. So some ED visits and some hospitalizations in sickle cell are unavoidable. It's a complicated and serious chronic condition. But to our team, it's a clear health equity priority that to the extent possible, it's important that we keep patients with sickle cell out of the ED and instead have them engaged in comprehensive preventive outpatient care. Thank you so much.
Thank you very much for that, Dr. Eisenstein. And again, I'm very impartial to most of what you presented. But before we go on, for the record, please note Karen St-Hilaire is representing Molly Wasso Park in a voting capacity. And I'm going to poll everyone for questions. Dr. Babette?
Two quick questions. The first one on sickle cell, since you were talking about it. It seems to me like education would be a key component, and I was trying to understand how hospitalized because of diabetes that is out of control, then people are exposed to it, the clinician team, the whole clinic, nurses, doctors, everybody that is there, but somehow in sickle cell, it sounds like they're not from what you were describing, so I wonder whether there's an element of that where if I'm hospitalized I have sickle cell, I'm hospitalized in one of the hospitals with like a lower volume in the plot here. What kind of, I was trying to understand what kind of access, what kind of care do I get so that the person that is sitting there understands what I'm going through and sees me, and does the Queen's model includes elements like that?
Thanks for that question. One of the challenges is that when we don't have an adult sickle cell center associated with a given facility, those staff on the inpatient side or in the emergency department don't have a place to refer them. They're ending up having to refer them to the Mount Sinai Sickle Cell Center or an outside referral. So limited options in terms of where to refer them to. In terms of the question about education and awareness among staff about sickle cell, there's pretty good awareness about what a sickle cell presentation often looks like. One of the challenges is that the patients who are cycling in and out of the emergency department and in and out of the hospital are often the patients with the least access to outpatient care. They're not getting the preventive medications like hydroxyurea is a key one that can prevent sickle cell crises. And so you're encountering patients with the highest burden of sort of inadequate access to care. And another sort of aspect of the vicious cycle of that kind of sort of scenario of sickle cell care is people often get sort of escalating needs in terms of what opioids are required to adequately manage their pain. So to my mind, it's not so much a problem of education on the inpatient side, so much as it is prevention of that hospitalization. Now, one other thing that I'll say is that there are parallel efforts going on within our system to improve and systematize what's the approach to patients with sickle cell in the emergency department and on the inpatient side. And so parts of those efforts are going to be education as a sort of byproduct of having a plan that's both a general system plan for sickle cell, but also ideally a patient-specific plan. So one idea from the emergency department that's emerging is if someone could have sort of a care plan that shows up as soon as you open their chart. So if they do show up, if they're known to Queens Hospital, but because of what they were doing that day, they had a pain crisis, they showed up at Bellevue, the Bellevue emergency room doctor would be able to open up their chart and have immediate access to a care plan that's been sort of pre-established with the sort of participation of that patient.
Got it. Thanks.
I actually would like to ask a question here, and it's kind of in vein of what you were asking, Jose, and I think it has a lot to do with the quote of the patient that you started out with when you were discussing sickle cell. The drug-seeking behavior that patients are afraid of being treated as if they're exhibiting. I'm hearing that question from Jose kind of. I think that's, whether or not they're encountering that in our EDs. Like, that's the question. What was so frustrating for that patient when they presented that they were afraid, right? That they were feeling teary-eyed because they know somebody's going to suspect or think first, I'm drug seeking versus I'm really in pain. So I think, and I know with that comes a lot of biases that people have to deal with. And I don't know if the provider has inherent biases towards the patient, and the patient also towards the staff, not knowing what they're going to get from that day. So I think for me, I would love to hear what has our exposure been to whether or not staff understands that people don't want to be treated as if they're drug seeking, and that the patients that are coming, that we address it so that they absolutely do not feel that way.
Absolutely. And I think, this awareness raising event from Office of Quality and Safety from April of 2023 was a really powerful example of trying to raise awareness. I don't have eyes on how widely that was seen by facility level staff, but totally agree that would be part and parcel of any successful and sort of comprehensive system-wide plan, is to optimize sort of education and awareness for frontline staff about what is a sickle cell, what does a classic presentation look like with sickle cell? What are some of the traps of biases that staff may fall into? To your point, like thinking that someone is, telling a story of pain as a secondary motive of seeking pain medications.
So I actually have one comment. One of the things we're looking at is, do our providers represent our patients? And if you look at the two hospitals that actually have more admissions per patient, looking at the demographics of those hospitals, the percentage of African Americans, at Kings County is 80% of the patient population, and at Bellevue, it's 18%. And South Brooklyn, it's 14% of their patient population. So the patient population that the providers are seeing have fewer African Americans in those facilities. What I can't tell you is what the providers look like in those facilities. So I think they're not seeing as many patients, may not be as sensitive to those patients because they're not seeing them. And would it make a difference if the provider demographics were different?
I was thinking about training, any sort of training in that.
Thank you.
I had one very quick question, unrelated to this. So EGFR, is everybody using the same equation now? You and the payers and the transplant folks, or are we the only ones dropping one variable from the equation?
We're certainly not the only ones. All of the major professional associations for nephrology have now officially recommended removing the race adjustment. And so now it becomes a process of operationalizing that change. So H&H was an early adopter of that change, but other systems are doing that. And one of the goals of the DOHMH coalition was to translate that, desire into actually a change.
The reason for my question is when you show the data, the number of people that now fall into a high risk category are huge. You double basically if you look at the plot you had there. And so then let's say that I am classified now as high risk, and I've been told I need a transplant. Does the health plan pay for it if they use a different equation? And do I go into the queue for that?
Yeah, so there's definitely, I can say with some confidence that there's uniformity in that sense. Like the payers will accept the EGFR algorithm of the given health system. And so it's really about, there is some, in the weeds of sort of specialty research, there's discussion about what's the best version of the future algorithm. But for our intents and purposes, there is sort of concordance of, okay, we're going to agree that an EGFR that's not race adjusted is preferable. And so no one, to my knowledge, has encountered any issues where they've used a race-free EGFR and then a payer, for example, has come back and said, oh, we use a different algorithm, we don't accept this.
Thanks.
Karen and Hilaire, you have any questions or comments? No? Jackie Rowe Adams?
No, y'all asked them all.
Okay. Thank you. Okay. Next is an update from the Vendor Diversity Report. Keith Talby?
Hello, Keith Talby, Chief Procurement Counsel. Thank you for having me and the opportunity to present Dr. Martone and Dr. Devon. The first few slides here are a little background about our vendor diversity program at Health and Hospitals. I report into our Chief Procurement Officer, Danielle DeBari, as well as our General Counsel, Andy Cohen. And I sit with our supply chain team. We work together with our policy and our processes and our supply chain team to make sure that our system spends a fair share of money with diverse and women-owned businesses. We've had a program since 1998. In 2015, shortly after the centralization of our supply chain, we have expanded our program to really align more with the city MWBE program, and that has really been effective, having the city as a partner, because they've been very proactive in making sure, one of the key pieces there is that they're certifying businesses, and that those certified businesses are staying certified and up to date and are active participants looking for business. Next slide, please. In 2017, we revised our policy to add additional tools. So those additional tools are really important in our process. They really give MWBEs a competitive edge in our procurements. And that means that if there's one vendor that comes in at, let's say, 100 points, or 90 points rather, and is non-diverse, the diverse business can get 10 points and then win, all other things being equal. So that 10% difference makes a huge, significant competitive advantage for MWBEs in our procurement, and it really allows them to succeed. One of the things we're always trying to overcome in providing business to MWBEs is the inertia, or maybe the momentum, but the lack of wanting to switch vendors when we're dealing with our business partners internally. So that really helps. So we have that MWBE as a quantitative scoring factor in the evaluation of solicitations. We also do MWBE only solicitations or closed pool solicitations. So when we identify an area of opportunity that is ripe for MWBEs, such as furniture, we say only MWBEs can participate in that space. Same thing with marketing and advertising, which we did with T2 and spent millions of dollars for marketing and advertising with MWBE only firms. And then discretionary purchases. This is less significant in our organization because of our centralized supply chain. We really look for and issue contracts to vendors instead of having decentralized purchasing where front-end staff or end users are making purchases. So we don't have a lot of smaller purchases across our system, but when we do look for MWBEs to participate in that less than $1 million discretionary purchase method. We have standard processes and controls that are in place to ensure that every procurement has consideration of MWBE. This is really where the rubber hits the road. We can do a lot of things and say a lot of things, but without a control in place, there's no real effective way to make sure it's going to happen. So since 2018, all of our contracts have been reviewed for MWBE compliance, and all of our RFPs have, that should be updated, have goals on them. They may not always be 30%, depending on the availability. Since 2019, all RFPs have quantitative scoring, so that's the 10% I was referring to, and since 2021, all RFPs are reviewed for MWBE goal setting and strategy, and all of our service contracts greater than $1 million are also reviewed by our contract review committee to ensure compliance with our procurement policy and our vendor diversity policy. So with these changes, you can see on the next slide that we've had really, really great success. We were at 5% back in 2018. Last year, we were at 35% or 734 million. We are trending right about at that same target this year. I will say that 734 million represents about, of the eligible spend, is about half of supply chain spend. So we spend money for other things such as doctors or pharmaceutical supplies or MRIs, all of which are not part of the program, or utilities, because for those items, there are no MWBEs available out there to provide us with those things. So where there are MWBEs, that's about half of supply chain spend, we have 35% of that spend going to MWBEs. Next slide. So this is just a graph of our growth over the years, so you can see both the dollars and the percentage have increased dramatically since we've enacted these new policies with the leadership and support of the board and Dr. Katz and Dr. Clary. Next slide, please. So this breaks down our total eligible spend, which I was saying is about half of our total supply chain spend. And then the next box down is our total contracted spend. So that is direct spend to MWBEs. When we issue a solicitation or do a bid, MWBEs are welcome to participate, and if we award that work to that vendor or that contract to that vendor, then that is the spend that's in that box there. And then the total subcontracted spend. So if we are contracting with a vendor that is not an MWBE, we ask them to subcontract a portion of their work to an MWBE. Typically that's around 30%. It can be as low as 5% up to 36, 40% depending on the type of work that's being done. we're really proud that that growth year over year has increased such that now that subcontracted spend is almost equal to our prime spend, right? So those two numbers are now like almost a one-to-one match, and that really represents the strength of the program that we have and the continuing success, because that's the day in, day out, really hard work of the program. So having prime vendors that are not MWBEs, setting goals on those contracts, negotiating with those vendors to make sure they agree to these goals, and then staying up on top of them month after month after month to make sure they meet the goals that we've set. So you can see the utilization rate is 28%, 32, 35. And then the other number that we track that's really important is how many diverse vendors are we doing business with? You know, it's important obviously to have spend with vendors, but it wouldn't be helpful if we had a small pool of vendors that we were just spending a lot of money with. So we've been able to successfully increase the number of diverse vendors that we're doing business with significantly year over year. On the next slide, we break down the types of certifications that vendors have. You can see that most of them are certified either by the city or the state or dual certified, and then a small percentage is others, 4%. So that's typically either a private organization like NMSDC, which certifies minority organizations, or WeBank, which certifies women-owned organizations, and then some outliers like the Port Authority of New York and New Jersey, which does their own certification process. The next slide, this is spend broken down by ethnicity and gender. You will see here that depending on the year, this can vary widely depending on what we're buying. But the Asians seem to be overrepresented here at health and hospitals, and that's in particular because when you look at the number of diverse businesses in the certification directory, a lot of them are in the IT space, and we have a large amount of IT spend. And so that number of Asian males being proportionally overrepresented is the reason. However, we are doing very well with Black, Hispanic, and Asian-owned businesses, and we're very proud of that. And you know, one of the focuses that the city has is the disparity within the disparity. So when you're looking at MWBE programs overall, it's often the case that Black-owned businesses, Hispanic-owned businesses, and Asian female businesses get less work. So it's skews more Asian male or women-owned businesses, and we've done rather well on that. Next slide. So our two biggest business partners internally are our facilities group and our IT group. So this is just some data reflecting their overall utilization. This is not an imperfect measure, but looking at our PeopleSoft data and the accounts in there, you think it's a pretty accurate, rough approximation. So OFD is 35% year over year, and that's actually pretty consistent with the book of business that they have. So a lot of construction projects sub out about 35% of their work, and they're able to sub out a good portion of that to MWBEs, as well as some prime work with MWBEs. There are a couple of prime construction companies that have done a significantly good job for us, and non-MWBE primes, Consigli, which I believe is doing OTX-HU at Bellevue. The next slide has the IT team's work. You can see this is where we have such large numbers, 46 and 65% overall. Hatora has multiple large contract awards. Coronet, just some of our top performers, so we have some flavor for what we're doing here. And G-Systems as well, which is a catering contractor. Next slide, please. Major accomplishments for the team. We won our Premier Supplier Diversity Award. Premier is one of the country's two large group purchasing organizations through which member hospitals participate and enjoy contract savings and the availability of contracts across the country. So we won that award and are very proud of that award and received that award. Major contracts awards for the team of $2.1 billion include 717 in contracts or subcontracts, $217 million to LICCOM for migrant hotel food services. I should also mention that all of our, so since the beginning of HERC, we have included all of HERC or the asylum response in our program. You might hear different reports out there from or news articles about MWBE and HERC. We have included the entirety of HERC in our MWBE program and not exempted it despite it being an emergency contracting situation. And that includes a large award to LICCOM for food services, as well as other MWBEs that we're working with and lots of subcontracting that we've been staying on top of there. We have a lot of temp staff, and our right sourcing partner is the vendor that manages that for us. And we've worked with them and selected them in part because of their history of success with MWBE. Their utilization year over year has grown. And they've been a real partner in helping MWBEs grow. And they do weekly touch bases with their MWBE suppliers and really help train them and teach them how to run their businesses in this space to allow them to succeed. Some months we have had up to 40% MWBE utilization with right sourcing as a result. We also partnered with SBS to support a new vendor, gaining MWBE certification for COVID test kits of $40 million. And EITS also partnered with them to work on a separate supplemental staffing contract for them, and 6 of the vendors awarded their MWBEs. I mentioned before that we do these closed pool solicitations when there's lots of MWBEs in the market space, so only allow MWBEs to participate. We had 2 large awards there, $200 million to a Dell reseller, so all of our computers and accessories, a company called Agilent. And the first one's the computers, the second one's the accessories derived. So communication and outreach is a big part of the program and where we're beginning to focus more. So overall, the city has a goal of about 30%, or actually has a goal of 30% MWBE utilization. We are fortunate with our success and our support here internally that we've been able to achieve more than 30%. And now this program is not entirely self-sustaining, but we've built a good foundation that it is sustaining with the continued work of the team. So we're able to focus on some more of the mature aspects of a vendor diversity program. So this is communication and outreach. And this allows us to target specific communities, specific areas of need within the organization, work on capacity development, finding smaller vendors, spending time with those smaller vendors to help them gain access to a system as large as ours and to grow. So we work on mentorship from a prime vendor or another successful MWBE to work with smaller MWBEs, as well as, so we have a website to allow vendors to understand how to do business with us better. I find it interesting when we speak with our MWBEs because they come to us and they're very confused as to who and what we are. We're unique in the city, being a public benefit corporation in that part of the city itself. The city's hard enough to do business with us, so it's really important that we speak in simple, non-legal, non-jargony terms to our MWBEs to help them understand where to find the opportunities are to do business with us. And we also teach them how to do business with the city also. I find often there's just way too many acronyms out there. So it's very helpful. Our website is in good plain English, I think. It really, and provides an email address directly to us. Then we're get emails every day from MWBEs out there looking to do business with us. So that has been successful. We go to fairs and have also begun working with other hospital systems and IDNs to begin discussions about how we can leverage our success with other hospital systems starting locally, as well as through the Premier GPO. I sit on their Supplier Diversity Council, and we discuss best practices there. The last slide here, this is really some of the key steps that we were working on in the recent past prior to your chairship, Dr. Marthone. So just wanted to show that this important work has really been completed and is now allowing us to work on some of the more mature aspects of the program. And then here at the bottom, some of our next step in program objectives include maintaining our 30% utilization, increasing the number of diverse businesses that we're doing business with, working on the disparity within the disparity and working with City Hall on that. We've been in close contact with them, as well as increasing our capacity program, so making sure those small businesses continue to grow.
Thank you. Thank you. Dr. Pagan?
Just, it's always, the work that you all do is very impressive always, and very proud of it, because we've been working, we meaning the whole system has been working on it for a while on this, and it's just nice to see that. I guess one comment that I had was on when, I'm always curious as to why people do not apply or businesses do not apply, and I don't know if there's a way of collecting information, like what is the biggest issue of
To get certified.
why is it that, yeah, or
Apply to do business with us or apply to get certified?
do business, like are they you mentioned one good example, which is like it's a public corporation compared to a city agency, so it may be confusing, but
I'd say two things. One, they're not used to a formal process. So a lot of our bigger opportunities have a very formal process for participation. So because we're a public entity, we have this formal RFP process, which a whole bunch of rules where we put out a document and say, oh, this is how you have to be able to participate with us. You have to submit a proposal. It has to be in this format. It has to be in this method. And I think for lots of companies, preparing that document and understanding it in the first instance is really confusing. It's like doing your first term paper. You just don't know where to start. So the first thing that you submit really may not be that good. And even though your company may be great, what's reflected on paper for you is not. One of the things that I suggest to our vendor diversity, our diverse businesses, is that they hire a graphic designer to help them make a nicer looking submission, because everything could be there. It could be a great substantive submission, but it doesn't look as good. And that really can make a difference when the evaluation committee looks at the document. It just doesn't look as professional. And then the other thing that's difficult is the opportunities that we issue. We look at the vendor diversity certification directory, and we try to find our businesses that might be able to do business with us. And we directly call them, we email them, and then send them the opportunity. But sometimes they don't have an email address that's set up. These are kind of like in the weed things, but they just don't maintain the right form of communication. So that's one of the key tips that we give them. Sorry, Saba Hazel is with me, our AVP of Vendor Diversity. And another being on the city side, if we don't know you're out there and you're looking to do business with us or the city, you have to know where to look. It's not obvious at all. So you need to know how to use Passport. You need to know how to use Checkbook NYC. You need to know how to look at City Record Online. So it's just a hard way to understand. So when we do these outreach events, that's really what we're training on, is saying if you want to do business with the city, these are the 3 places to look. This is how you do it. And we actually just do a demonstration. So we'll have a slide deck. We'll have the link, and then we'll go into the link and we'll type it as if we're a new user who's never done it before, and it really helps them.
so I don't know if you keep track of all of that, but maybe I don't keep track of who I talk to on a daily basis, but sometimes I feel like I should. But I wonder if there's a way, because it's a win in a way, right? Because it would be nice to know, okay, I had 20 businesses that I spoke with, or 20 MWBs that I met at a meeting, just to see how many of them
Some of that
go
data.
through. And
We haven't found a great way of collecting it, but Saba set up a Google form at some of our outreach events this year, and that has been helpful for us to look back at some of those.
And what triggered my question at the beginning was, like, sometimes I see solicitations and I see, people, we spoke with 20 different businesses, but only, I don't know, 5 or 10 applied. We always wonder, like, why did the other ones didn't bid? And,
Yeah.
I know it's not MWB specific, but you even wonder that, so.
Yeah, that is some of the more mature work we're looking to do, that outreach work after solicitation is closed, to debrief with vendors, both from our side and their side, to say, what are the things, the impediments to access, essentially, right? And we talk about that at lots of the meetings that we have with MWB.
Very good.
Thanks.
Thank you. Dr. Al?
No questions.
Karen Sahler?
I do have a question, only because I do MWBE at DSS. And I applaud you, actually, it's not a question, I applaud you for the prime number and your MWBE spend being so close, because that's so hard. You guys are doing a great job. I know your questions are like really digging deep, but it's like, it's really hard at times to get a prime to agree and stay the course. It's painful. It's like pulling teeth
Mm-hmm.
with no Novocaine. Getting them to agree to the goals and just having them follow the rules is pretty difficult. So I applaud you and your team for that.
Thank you very much.
Jackie Rowe?
Yes, I just want to say congratulations to you because it's a as you say, it's a lot of work. But you did answer the question indirectly for outreach. I think more outreach need to be done. I think more training. I think the chair alluded to training and education. This is hard. It is, and all the stuff you told me they had to do, I was getting tired just listening to it. No, it's a lot of work. So, but do you have someone that could really say, if I came in and I have a clue, but I don't have a clue of really how you go through the process? Do you have a one-on-one or a class that say, oh, she's really interested, she got a nice project, she want to be, do you have someone to sit down with them to
We
do
do.
that?
We
I didn't
do.
hear that.
Yeah. So through that website and other forums, when vendors reach out to us, we call them, email them, happy to set up time with them if they have any of those questions. We have a deck that we, is kind of like a canned deck that we run through some of those key steps in how to do business with us or with the city. We don't do kind of broad MWBE training. It's usually more focused to our particular solicitations. The city does do all that work, and I don't know, we can consider it, but it's harder to find the right audience and also maybe not step on toes if we're doing that type of outreach and education to the vendor community.
If I may piggyback, SBS does it.
Yeah.
Right? And I think they also keep a roster. So even if we don't have the roster, they have the roster. But the application process itself is time consuming. It might be a little daunting for some because it takes a long time, right, to just go through the process, the background check and everything else. But SBS definitely has that information and the training classes. And most of them are free, right?
All of them are free.
How to be an MWBE, what you need and everything else.
So, but I'm glad to hear that you might consider it, and
Yeah.
it's something for you to think about.
Yeah, please.
Yeah.
Thank you for the advice. Thank you.
So I just, thank you for the work you do. I know it's a challenge. I'm looking at the percentage, 1% Black female, 2% Hispanic female, 11% Hispanic male, 14% Black female. And just what thought have you given to innovating or looking at the processes that we have in place here at H&H that might actually have biases built in to preventing these individuals from improving their numbers?
You know,
You don't have to answer that now, but if you do have an answer, great. But if you don't, then maybe, next time, because I think it's a big question that you
Yeah.
might have to go look and reevaluate with that lens.
I will take that back.
Okay, thank you.
Thank you.
So, there's any old business?
One more.
Presentation.
Oh, one
We have
more?
our
Oh,
EEO
I'm
update.
sorry. Next, I'm just gonna skip over you. So sorry. Next is an update from the Equal Employment Opportunity Report, Blanche Greenfield and Nicole Phillips. My apologies, ladies.
Right, good afternoon, everyone. My name is Stephanie Siao. I'm an associate counsel with the Systems Office of Legal Affairs. I'm standing in for Blanche Greenfield, the Chief Employment Counsel, and Nicole Phillips, the Director of EEO, who both unexpectedly could not report today. Next slide, please. So the Systems Office of EEO is responsible for maintaining and implementing the system's EEO policy. Should I stop for a minute? So that.
Good job. Good afternoon, Dr.
Yeah, oh, I can say it out loud?
But all of you have important jobs. Why are you watching me?
Oh, we were watching you to prepare for Monday.
You
Oh.
got
We were like,
excellent,
what-
excellent, excellent. I'm sorry. Go ahead.
Please go.
All right. So the Systems Office of EEO is responsible for for maintaining and implementing the system's EEO policy, which does cover reasonable accommodations for the system and internal complaints alleging discrimination. So this first slide goes over the reasonable accommodations that were requested by system employees from calendar years 2020 through 2022. Um, as you see, there has been an increase in the number of accommodations requested. In year 2022, there were 2,445 requests received, as opposed to year 2020, in which 2,334 requests were received. I will tell you that there is a large number of requests for telecommuting, so the ability to work remotely. And so we've seen an increase, particularly in that category. Next slide, please. So this slide deals with the RAs, which is short for reasonable accommodations that have been requested, and the status of these as of December 2023. So the first three columns go over the number of reasonable accommodations that were approved. And then the next category is the total number that were denied. And the next category is the total number that were administratively closed. And I'll explain what it means for it to be administratively closed. That is when a request is received and the employee either no longer needs the request, maybe their situation has changed such that the request is now moot, or sometimes the employees do not submit sufficient documentation to support their request, which does not enable the Office of EEO to review the request. In those cases, also the request would be administratively closed. Or it could also be that maybe the employee has left the system. So again, that's another circumstance where the request would then be moot and would be administratively closed. This slide deals with the number of reasonable accommodations that are coming in by title and breaks down where we're seeing the vast majority of accommodations requested by the person's title with the system. So as you can see, the numbers for coordinating managers, PCTs, clericals, service aides, PCAs, and nurses are particularly high. I think, you have to think about the nature of the job the person holds and whether or not it's physical, because often the RAs are tied to their medical condition, and maybe if the work is physical, it may prevent them from being able to fully do their duties without an accommodation being in place. So as stated previously, the Office of EEO also investigates internal complaints filed by employees for the system. This slide does go over the number of internal complaints that have been received by the system from years 2020 through 2022. We have seen, the Office of EEO has seen an increase in the number of internal complaints, which could be because maybe employees are back on site fully. We don't have as many working remotely as we did during the pandemic, and maybe some of these interactions have led to an increase in the number of complaints filed. So the slide categorizes the status of the internal complaints that have been received. The Office of EEO issues determinations for the complaints that are received after the completion of an investigation. One such category of a determination is reasonable cause, where there is reasonable cause to believe that the allegations that were alleged by the complainant have actually occurred. So the first category deals with the number that were closed with a reasonable cause determination. The second category deals with the number that were closed with a no reasonable cause determination, where the Office of EEO, after an investigation, has determined that there is not enough evidence to support the allegations claimed by the complainant. So the investigation is closed with a no RC finding. The third category deals with the number that were administratively closed or withdrawn. Um, Again, I'll explain what an administrative closure means in this situation. It could be where the person who's alleged to have committed these acts, the respondent, is no longer employed by the system, which will not enable the system to complete the investigation, or it could be that the complainant has gone on to file an external complaint, so has filed a complaint of which the basis of the complaint is the same as what was alleged internally, but they have now filed it externally with one of the external civil rights agencies. And so as a result, in that case, the system would respond to the external complaint and the internal complaint would be closed. So the system's response to the complaint would be to the external and not the internal, since the basis of the two are the same. So that would be an administrative closure. And the fourth category deals with those who are pending, remain pending. Okay, and the last category is those that were closed, and the determination was that the allegations didn't quite rise to a violation of the policy, but there was some behavior that was inconsistent with the spirit of the EEO policy. And training is always done in that situation. This slide explains the internal complaints and the basis of which the person is alleging their allegations of discrimination. Please understand that multiple bases can be alleged in an internal complaint. So this chart, while it does explain the basis that was selected by the complainants, doesn't necessarily tie to the number of complaints that were received, because a complaint could be categorized under multiple bases, so it could be categorized multiple times on this spreadsheet. So you'll see that there are obviously a large number of complaints under sexual harassment, also to race, retaliation. It does go through all the bases listed. There has been an increase in the number of sexual harassment complaints as opposed from 2020 through 2022. That could be a result of the robust training on sexual harassment that the system gives, thanks to Ivy and her team. Or, I mean, also again, too, the fact that many of our employees are back on site and interacting, and those numbers are higher than what they were in 2020, when, as a result of the pandemic, many employees were remote. So this slide explains the external complaints that we receive by year. As I explained, the employees who are alleging allegations of discrimination do have the option of filing externally with any one of the external civil rights agencies. That could be the City Commission on Human Rights, the State Division of Human Rights, or the Equal Employment Opportunity Commission, the EEOC. We have also seen a significant increase in the external complaints that are filed by employees. Again, that could be a number of things. It could be, again, that people are back in person. It could also be that, I'll also explain this, the external civil rights agencies will take in complaints received by people who are filing these complaints. There's no real vetting of the complaint to ensure that it actually does meet a discrimination complaint. So you'll find that people can check a box to allege the type of discrimination that they believe that they have endured. But then in reading what the events that they say occurred, it may not meet that level of discrimination under the law. However, the civil rights agencies will then still submit the complaints to the system for a system response. So there has been an increase in the number of externals that have been filed.
Let me ask a question that I think both illustrates and something I wonder about. Complaints, people complain a lot to me, which I encourage. I have an open, policy about complaints. People who say there is discrimination, that's very clear. No question, off to EEO. The ones that I struggle with are My boss is bullying me. My boss is requiring that I do X and Y and Z. There's no one, it's not suggested anywhere that that is because of any protected group. But I'm never quite sure. I mean, my tendency has been to send them to EEO. Is that what we want, or what is the right? I mean, I often will. I mean, I always try to say something, positive about, trying to focus on work and our patients. But of course, I can't possibly investigate whether somebody is being bullied or not being bullied. That's what people, please tell, my supervisor to stop bullying me. Well, so usually I say something about, well, I can't, every story has two sides, but how, as a system, how do we believe that those kinds of complaints should be best handled?
Well, the system, the Office of EEO does often receive complaints that don't fall under its jurisdiction. The Office of EEO is solely there to implement and maintain the EEO policy. So a complaint of bullying that is not specific to a protected category would not be investigated by EEO. However, EEO would then refer it to where it needs to go, and that could be depending on the employee's status, or the respondent status. It could go to the Office of Labor Relations, or it could go to Human Resources, but it would be looked into. And if there's obviously a physical component, maybe hospital police would be involved as well, because it would address workplace violence.
Okay. So I'm not entirely wrong to send them to EEO because you're triaging. But if you said that I shouldn't send them to EEO, then that I should try to triage them in that. I think one of the reasons I'm concerned is that, right, someone is bullying. How do I know that they're not being bullied because they're in a protected class?
Right.
Usually people don't tell you whether they're in a protected class or not. So I often feel like, well, how can I know whether or not this could be, maybe the supervisor is bullying them only because of their gender or race.
So that's why EEO would look into it, and may even speak, depending on what is alleged in the email, if it's a received email, or however the communication received, would have a conversation with the person who is making the complaint to determine whether or not it is for EEO or should be referred to another department for investigation.
Okay.
So this slide deals with the status of the external complaints as of December 2023. We have been finding that some of the external agencies have not been issuing determinations. For instance, the CCHR has not been making determinations as to whether or not there's probable cause or no probable cause for the complaints that they received. Instead, what has been happening is that they have been closing out the investigations, administratively closing it, which I think is skewing our numbers, but does not mean that there have been additional findings of probable cause. Really, they just have not been conducting full investigations, have been closing out the matter, which then allows the complainant to then file a suit in state or federal court.
And that's the City Commission on
That is the
Human
City
Rights,
Commission
just
on
so-
Human Rights, yes, CCHR, sorry.
Yeah.
SDHR has still been issuing determinations, and we have found that, sorry, again, acronyms,
Yeah.
State Division of Human Rights has still been issuing determinations, and we have found that for the vast majority, the determination has been no probable cause. So finding that the system or the respondent, the person who's alleged to have committed the discriminatory acts, has not actually done so. So it's been no probable cause finding. So you'll see that the looking at the categories, when you look at the last category, dismissal and notice of right to sue, the number is quite high, 35. But as we said, we have found that they have been closing these out. Again, if you look at the third category, total number of administratively closed withdrawn, the number is 10 for 2022. Again, an increase, but as we said earlier, these have been closed out, but without a full investigation. But we have found that where they are fully investigated, generally the determination has been no probable cause. So this slide does explain the bases for which the external complaints have been filed, so the categories that are being selected by those who are filing the complaints as to what the basis of the allegations are. And we have seen an increase in religious. I think that comes from a lot of the COVID issues that we had, and that many employees did request to be exempted from the COVID vaccine due to their religious beliefs, and then were, if unhappy with the decisions that were made with the system, then went and filed external complaints alleging discrimination on the basis of religion. So we've seen an increase in that. There was also increase in disability. Again, I think that is tied to COVID for those who were asking for medical exemptions from the vaccine mandate. So there's just been obviously an overall increase in the number of externals that were filed. Again, too, complainants are able to check whichever box they feel fits their basis for alleging discrimination, even if it may not be one that would meet that under the law, but they are able to check whichever box they would like. So in some cases, they are checking multiple boxes as well. So this is our slide dealing with, sorry, can you go forward again to the sexual harassment 2020 to 2023 slide? Thank you. So this is regarding the determinations that we received on sexual harassment complaints. And as I stated earlier, NPC, we are receiving mostly no probable cause determinations. That number is quite high. There have been some for which parts there was probable cause, and then there are others that are administratively closed, or there no reasonable cause but inappropriate, inconsistent with the EEO policy. And lastly, the slide deals with the sexual harassment training that the system has implemented. As you see, the numbers are very high. The training is robust, and our employees are generally in compliance with having completed this training, which I think, too, again, brings about the awareness, which is why the numbers for the complaints have steadily increased, because employees are educated as to their rights under the policy.
Thank you very much. Thank you. I'd like to thank everyone for their presentations today. We really do appreciate the hard work that you're doing, and for obvious reasons, I think you should be congratulated for your reports, and we look forward to hearing you next time as well. Any old business?
I have a question.
Sure.
I'm sorry.
Oh, I'm sure, forgive me. Go ahead. Yes.
Again, so I do EEO at the office as well. I find that on page 64, when the numbers for sexual harassment is high, and I experience the same issue that you have, do you find that a lot of your complaints are filed under sexual harassment, but it's bullying, sexual harassment, but it's something totally different, which then skyrockets your number? It skyrockets your number, but it's not really a sexual harassment charge. Do you find that a lot?
I think that does happen with both the internals and the external complaints, where the person perceives the behavior maybe as sexual harassment, but if you look at what the law requires, it doesn't quite meet sexual harassment.
Right.
But this is what they've perceived it as, so this is what they've selected in choosing the basis of their complaint.
Right, so what we started doing when we are presenting to the body is stating that, because they're like, oh my gosh, look, this a high sexual harassment filings, like what's going on? So we're very clear to say, yes, the numbers are high, however, it's misfiled. It's not really sexual harassment when we looked into it. Externally, internally, it's not really that, but in the spirit of the law, this is why they submitted it that way, so.
Right. Because the employees, they're able to self-select. Sometimes they choose that, or this is what they perceive it to be.
Again,
And we
hard
don't
work,
really
great work.
Track it that way, right? We just track there was any basis for it to be,
We are
likely,
tracking the box that they've selected.
that they-
That's it.
Yeah.
I do want to state, I'm sorry, did you finish? I wanted to state for the record that Dr. Katz did come in, so he is present now. And I will poll the members if they have any questions. Dr. Pagano?
No questions,
No.
thanks.
Dr. Katz?
No questions, thank
Okay.
you.
Karen St. Hilaire, do you have anything again? Okay. And Jackie Rowe Adams? Okay. Any old business? For the third time? Okay. Any new business? No. Seeing there is no further discussion, meeting adjourned. Thank you.
This meeting is no longer being recorded.